came on.
All right, and we are live. It is a pleasure to be here with these three rock stars, and we're going to have a very exciting webinar today. First and foremost, wanted to thank all of the people that have registered for this webinar. We have some people from different health plans around the country. We even have some people from Urban One.
Very exciting webinar
On
today. First and foremost,
the stream today. Yes, everybody can mute. So we're very excited to have Joy Chevalier, who's the CEO of the Cook's Nook, Dr. Fedoria Rugless, who has so many titles, it's difficult for me to grasp all of them. But she is an educator, and she also is a director of population health, and she works within the church health and America Group systems. And then Julianne Eckert, who I've known for quite some time, she is a director, works in the HEDIS Stars world, which is from where I came. So Julian and I commiserate and talk about our experience. She's joining us during HEDIS season. So we give an extra special shout out to her and thanks for her to come on. But we're discussing food is medicine today. And we really want to give the Cook's Nook the opportunity to showcase the amazing offering of products that they bring to the table that can definitely help your whether it's a ACO or a DCE or a health plan. Cook's Nook is a group that you really want to invest in and work with. So I've introduced everybody. I want to give everyone a chance to kind of speak briefly. We have a couple minutes. Joy, Fedoria, Julian.
Sure. Good morning, everybody. Thanks for joining us, James and Fedoria, Julianne. Thank you so much for being here. We're delighted. The Cook's Nook is a culinary incubator and food services group here in Austin, Texas, and we really focus on developing food solutions, menus, recipes that really speak to those organizations who are really looking to affect health outcomes. And here in Austin, we work in the public sector, but more and more increasingly in our healthcare and institutional sector, where we're working to provide solutions, not just what everyone eats, but also the data behind that as well, to be able to measure those outcomes as they go along. So we're excited to talk with everyone today.
Sounds awesome. I'm going to go right in to be mindful of time. So I'm going to start a lot of things to unpack during this conversation. We want to give Joy the chance to get us started off. Food as medicine is such an important topic right now. It's not something I've been in healthcare most of my adult life. I never heard the concept of food as medicine until the last 3 or 4 years. I wanted to give you, Dr. Rugless, a chance to start us off. When you hear biologists that really studies the qualitative and quantitative side of this business, what does food as medicine and the concept of social determinants of health mean to you?
So I'll unpack that first one. So everything that we ingest has an effect or impact on our body. And so the whole food as medicine concept is to get these nutrients or things that our body needs directly from the source, from its natural source, when it comes to things like our vegetables and fruits and things of that nature, versus not just necessarily relying on certain medications and prescriptions and things of that nature to cure certain ailments that one may have. So definitely more of a natural, holistic approach, but it is also a lifestyle thing as well. So if you're making it a lifestyle habit to eat these proper vegetables, fruits, and have proper nutrition, then you can combat a lot of the chronic diseases that ail so many of us, especially when it comes to things like diabetes and hypertension and things of that nature. Going straight directly to that food source can truly be impactful. Now, when you add the social determinants of health piece to that, that's where things start to get a little tricky, in that a lot of our population have not necessarily had access to the proper levels of nutrition, to the foods and fruits and vegetables that they need to be able to deal with some of those chronic diseases. And so that's why our population, especially within the African-American population and some of the underserved and unsure communities, don't have access to that. And those systemic barriers that have been in place for over years and decades of things, when it comes to things like redlining, or when it comes to neighborhood access and their grocery stores not being within a certain community and accessible, then all of these other diseases and comorbidities have developed that have impacted their health and well. If we're able to then provide these to them, then we can kind of begin to reverse some of those trends that we've seen when it comes to those numbers in their health.
Absolutely, Dr. Rugless. I wanted to toss the ball to you, Julianne, because you're a nurse, so you've seen it from the clinical setting, actually treating patients. So we really try to get a holistic group of people. Dr. Rugless, who's really studied this from a qualitative quant perspective. Julianne, who's a nurse, who's actually treated people in a patient care setting. And then, of course, our CEO, Joyce Chevalier. You see this working in the HEDIS world and the STARS world as it manifests itself in star ratings and actual attributes that we look at from a reimbursement perspective of health plans. How does the lack of access in certain communities impact star ratings?
For us, our mission is to improve every life, and we take that to heart, especially as our culture is organized into serving our vulnerable populations. And we particularly focus on screening, benefits, and coordination of care, because we understand that an outcome of the star ratings or the HEDIS ratings, that's really a report card of the health plan. And for us, in knowing that that's to do well on the test, we have to make sure that we're serving each one of our members. And each member is, in one of the talks I was on last year, she referred to each member as a snowflake, because everyone is completely different. And someone just in basic access of having to drive 2 hours to get a colorectal cancer screening because they have transportation, or they live in a healthcare desert, or having to make a choice between paying for food or paying for their medications or paying for rent. We never want our members to have to make that choice. And so we build that into our core benefit design to actually tackle social determinants of health. And we can see those smoke signals that we are improving and impacting exactly those populations in the outcome of our stars and our HEDIS scores. Particularly, one that we're particularly proud of is one of the HEDIS measures, diabetes and controlled A1C, controlled hemoglobin A1C. If a member has a controlled A1C, which is a measure of how well their blood glucose has been controlled over the last few months, we know that there's a pretty good signal that they're getting what they need, not only treatment, access to physicians, access to the right foods. And so hoping that with over 66% of our members who live in the top 5 ADI deciles for the Social Determinant of Health Index, we know that our populations are already vulnerable and disadvantaged. So that's a signal that our plans and our benefit designs are working, and they're able to access what they need for good health outcomes.
Absolutely. Joy.
Yes.
I am very curious. So had these two brilliant ladies tee it up. You're the architect. You're the chef. You're the person that's putting the tender loving care into each meal. How does this impact from the Cook's Nook perspective in the ingredients?
Yeah, I think what both Dr. Rugless and Julianne sort of speak to is the challenge on the ground for companies and businesses to take an active role in providing providing a suite of products for those snowflakes, but understanding that what we create directly impacts and can help and benefit those communities that we're serving. For instance, the Cook's Nook here in Austin was one of the ones that pioneered a prepared meals program for our city during COVID. And a lot of the work that we're doing comes out of that as we narrow further and further to sort of say it's not just generic good food, but it's actually food that actually supports specific lifestyles, specific outcomes, and helps mitigate risk. Because as Julianne said, we are working and providing meals and providing to vulnerable populations here in Austin, Travis County. That is primarily the work that we've been doing as a social impact business. And so the design of the food becomes critical in that you have to realize that the palates that you're trying to reach to ensure that they actually want to eat and consume this food and stay on plan and stay on target. And so it means you have to have a wide variety of things that reflect culture, interest in food, recognizes the fact that they may not have access. So you have to have a distribution mechanism and model. And then suddenly you're having a conversation on housing. And so it all ends up relating. And so that becomes the backdrop on a very large series of products and foods that you try to make available to support all of these different kinds of efforts.
Absolutely. Dr. Rugless, I want to ask you the next question. You've seen this both from the perspective of the hospital system and the health plan. Why does programs such as what Cook's Nook brings to the table and social determinants of health programs, how does it impact keeping people out of the hospital and overall managing costs and population health? You're in Memphis, which is a community that's had some struggles in certain parts of Memphis that are well documented. How does this granular program actually help outcomes?
So I think it's multifaceted, and one way with the work that I've seen that we've done here. Yes, we have looked into some studies into the impact of that when it comes to reducing the healthcare burden, preventing a lot of unnecessary ED or ER visits as well. Also, because we're centering and focusing on some of those determinants in addition to the food insecurity, that helps to address things when it comes to workforce development as well and job placement and things of that nature. So when you're trying to start addressing some of these things, it can have an impact in many areas. And so what we did within the church health arena, we developed what we call Cook Well, Be Well. And that was composed of different curricula where we taught them some of the basics when it came to some of the foods they needed to eat. We taught them how to adequately prepare them. Some people don't even know how to use a knife properly. So, how to chop vegetables, and then tweaked it. Joy mentioned earlier when it comes to their culture and their backgrounds within Memphis, this is a very, I don't want to say fat city, but we eat a lot and we do barbecue and, we fry chicken and everything else.
The best barbecue in the country, arguably.
Whoa,
correct.
Whoa.
We have a debate between Memphis and Texas, but we won't hold it against you for right now. But, being able to pivot a lot of these recipes and use different substitutes and things like that for the foods that they love, but to make healthier options or healthier variations of those foods. Yeah. And then we also address the insecurity piece in which we provide certain meals from them that they can come and take after they have a doctor's appointment, partnering with local agencies such as the Mid-South Food Bank, making sure that they have a steady supply of these items as well, that they can make it a part of their lifestyle habits as well.
Right. And that's just before you go on, I was just going to say about what Dr. Rose just said. And that to me and for us is the key part. How can you be in all of those places, whether it's, in their local bodega or convenience store, so it's there on hand, or it is accessible after a doctor appointment, or if you're talking about renal meals, maybe it's even available at the facility where they're doing dialysis, or even through different organizations that might be in their area and neighborhood. And you've got to have that supply that's easily accessible to them, no matter what those circumstances are around their household.
Julianne, wanted to give you a chance to elaborate as well.
Well, it's interesting, Fedoria, what you'd said, because one of the key points that speaks, really kind of popped out to me when you were saying that is how I learned to cook, and is watching my mother. I don't cook with recipes. In order for me to actually how to learn to cook correctly in a more healthy way, and not the pork chops and gravy that are fried and the peach cobblers and chicken and dumplings and everything, that was a whole shift. And I had to have access to those resources. And not only the food, healthy food is really expensive. And so that is kind of where, Clover is like, we recognize that. And our entire business is dedicated to improving the health and the health equity of our members. And we realize that to continually execute on this, we had to take a holistic approach to understanding all members' health needs and social health determinants that impact their own care and their health. And so we embedded that mindset into all of the technology we build, the clinical programs we roll out, and our member-facing programs. And the business results speak for themselves and show that we're getting it right. Our population is largely seniors, so they're in a different phase of their life. So, Joy, what you were speaking of, I work, with Clover. However, I'm based in Austin, Texas. So, and I did not realize that there was a Cook's Nook, and so access and screening and channeling are so important. And we embed that into our programs, because understanding who is vulnerable and needs support is so incredibly important, because we're not able to help support if we don't know what's broken.
Right.
And so we maximize the value of every single touch point with screening for red flag barriers of care and ensuring that they have the necessities such as a PCP that they trust and is local to them, and helping them find one, and even help schedule that first appointment to help make it easier for them from the very day that they sign up for our plan. In addition, helping them enroll in medications by mail, helping them apply for state prescription assistance programs and LIS benefits, knowing that once they get these, they may choose to go to another plan like a DSNP, which is richer. But for us, that really speaks to improving every life. And that's what we want for them. And if there's a red flag barrier of care identified, we immediately escalate that member to our health wellness teams to perform additional outreach and screening and wrapping a supportive matrix around that member and helping channel to community and government resources, and helping them get hooked up to programs like Cook's Nook, because part of it is just not even knowing what exists out there and then how to even engage with it.
And that's what's so fascinating, is that we're realizing, I think, and why each of us hear from these different aspects, because it is going to take an infrastructure that requires business, our healthcare navigation, those who are accessing people on the ground, doing that technical targeting and understanding of the populations and profiles and who's in our area and how to access them, and then getting this data. So this is not one organization or one company, but it has to be an infrastructure and federation, from the understanding the science and the impact all the way down to who's navigating and teaching in someone's local universe.
Joy, I wanted to go off script just a little bit, and I think you're the perfect person to explain this. Tell the audience the concept of what a food desert is.
All right. So you're going to get multiple answers around this, but I'll talk about what we do, how we use it here in Travis County for sure. So, when we talk about food deserts here, just a little bit, Austin has about 13 zip codes in the metro Austin area. We're talking about within 3 miles of our city center that do not have any food access, not just a grocery, but there's no food. There's nothing, not even a convenience store. There's nothing, right, in these metro areas. So when someone has to go, more than 2 miles or more than about 5 to 10 minutes to be able to access or get food, right? Or they're going without food for themselves, or they're going out without food because they don't have resources, or they're going without food because they passed what they have to someone else in their household or in their universe. That's typically how we talk about the extent and the frequency of a lack of food access or a food desert. A lot of people will also use the word food apartheid because, like Dr. Rugless said, it did line up, as particularly here in Austin, Travis County, with the building of 35 and the redlining that happened here in 1928. And our east side and our eastern crescent reflects that. And so, these deserts, you can also almost say that they're almost planned, right? And then have a discussion with grocers or others to say, hey, can you start to come into this area as a business conversation? So you got to be willing to have that conversation as well. It is truly complicated. Our city, our county, and then our agencies and then businesses here are really starting to rally around our Office of Sustainability and Austin Public Health to say, okay, we're going to end up doing this as a group, right? Food is not trapped within housing. Food can't be relegated to other areas that sometimes it's been a part of, but that it has to stand on its own and also be delivered, and the solution be literally delivered by partners, including businesses, to be a part of this.
That's a great explanation, Joy. We have a pop-up because we want to be interactive with all of the people that are taking their time to join this webinar. Somebody asked a question, and I'm going to toss this to Dr. Rugless. The pandemic must have exacerbated an already struggling food system. What trends are you seeing in populations that struggle with food insecurity?
Well, and this kind of piggybacking off of what Joy said earlier, if we did some GIS mapping with some of our regions and zip codes here in the area, and if you were to take some of these maps and when you speak to the food desert mapping, you take that map where the food deserts are, and then if you also overlay it with the zip codes that have the most poverty, and then you overlay that also with where most of our incidences and chronic diseases are, it's like identical. And so, you know, to the point of, yes, COVID definitely shined a light on, you know, this and brought to the light that, okay, this is something we really need to address, and how do we then change the narrative when it comes to these populations. And the food insecurity piece and the food deserts and the social determinants of health, you know, I think depending on your region, it may be different for where Joy is compared to where I am, doing an assessment of and lay the land as to, okay, what is it specifically within this region that we can address first, and then how do we target that and then change that narrative. So take, for instance, within our area, it was transportation. And so Memphis and Shelby County doesn't have kind of the same transportations as some of your other major cities when it comes to things like a train, or, I mean, we just have a bus system. That's pretty much it. And it can take a person like a day just to go to the doctor's office or just to go to the grocery store. And I watched a man yesterday when I was driving down the street, struggling from the grocery store to make it across the street. And he's carrying all these things in his hand to walk down the street to make it back to his apartment. Like, it just is not, it has been great for them to navigate that, you know, in these regions. And so, to the point, yes, it's further exasperated. But yes, it's like, okay, well, how do we change this narrative and address those key areas that impact is having?
Yeah.
Awesome. Julianne, I wanted to ask you, because one of the things that we get into, and I see another pop up, I wanted to give Julianne a chance to answer this question. The CAP survey, the Consumer Assessment of Healthcare Provider Services, is and the health outcome survey are so crucial to star ratings and reimbursement and just the stature of a health plan. How do these deserts, and really understanding these deserts and overlapping, providing care, providing transportation, pharmacy benefits, things like that, how does that weave into the tapestry?
It's critical, especially with those, you know, now CMS considers those, well, they've always been member experience, but they're weighted to a 4 compared to like a colorectal cancer screening, which is weighted at a 1. So you can see CMS is really placing huge emphasis that the member experience really matters. And that really all ties back into the experience that the member has with their plan. A lot of people think that CAPS is satisfaction, and it's not. It's experience of how they navigate through their healthcare with their providers and their plan. And one of the signals that we have seen, you know, is just, you know, questions and getting more information about simple things like the ability for them to easily access their medications at a local pharmacy or a mail order. If we have signals that, you know, members are having difficulty accessing these medications, that's a signal to us that there is something wrong and that we need to quickly intervene with that. And for example, you know, one thing that we've been doing to work with that is medications by mail, but also not, you know, it's easy just to have a doctor write a 90-day script, but the actual execution of that is so much different. Number one, is CVS or your PBM going to, you know, be able to deliver it to you in a way that makes you feel safe, that you don't feel like someone is going to steal your medications, or coordinating between all of those doctors. A lot of our members have multiple complex comorbidities and multiple specialists. So coordinating all of that is very difficult to actually, you know, be able to have mail order instated and on time. And that we assist with them and making sure that they're able to navigate through that, and all of those stars align and they can have those. So, you know, the CAP survey does show many different things, such as, James, you know, do you feel like your physician understood you? And that really speaks to, we believe that healthcare is local, and that members should be able to see physicians that they trust. And so we believe many of our plans have in and out of network parity so that they can see a physician, who they choose, that they affiliate to their culture, to their language, and they trust in those communities. And we feel that if a member is able to access a physician on that perspective, that they are more likely to go to a doctor more often and receive that continuing care and health management.
Yeah, that's such a critical component, is actually reaching out to the member, getting them to go to the doctor. And people on the payer side spend so much time and energy making that happen. People like Julianne and Dr. Rugless. A question that popped up, it is a really good question. I'm going to send this to Joy. Mental health is often overlooked when we talk about healthcare. How can using food as medicine help improve patients' mental health? I never even thought about that conceptually, but if you're not able to eat, if you're not getting a square meal every day, if you're struggling in that area, you're not going to take your insulin, you're not going to take any of your scripts, you're not going to take any of your mental health scripts. It's such a big issue.
Yeah, and Julianne, you began to get there, right? We do know that people will engage or not engage based on, not just the ease of access and familiarity and regular familiarity and placement of the item, whether it be a prescription medicine access or food access. But when you talk about food, which inherently has a comfort component to it, right, to ease these other activities, then you get really, really thoughtful about what the food is, what kinds of food last, what kinds of food can someone use in the way that they want to use it. In tech, I spent 20 years as a technologist targeting. We always talk about meeting people where they are, right? We don't ask them to come to us. We try to meet them where they are. And the food has to be able to do that so that they, when we talk about their mental health in relation to the food, is the food delightful? Does the food work for them under all the circumstances they want to use the food that's provided to them? Are they educated and feel comfortable and trust the source of the food as well? That's incredibly important. That's one reason we partner with so many people that they see and that they're familiar with already, that they're willing to take food and receive this food from, even if it's food that's new and different. And then the food itself and the composition of the food itself, right? What kinds of foods lend themselves to brighter energy, gives them the appropriate energy, not your simple carbs, but appropriate energy over time for the life that they're trying to lead, for example. So all that thought has to be there in the product so that people can be at choice, and the providers and those who are supporting them, who are accessing the food to make available to them, are also at choice to give them the right things. We spend a lot of time ourselves just sort of looking at literally the vitamins, food composition, food from around the world, that maybe that's just not part of the regular American diet or U.S. palate, to be able to say, is this something that can satisfy? Is this something that actually helps reduce, brings down numbers around cholesterol, or is it the appropriate source of protein? If it's a renal meal, how we ensure that, we're not seeing high numbers of, phosphorus or other things in that. And so, hopefully that the idea of the meal and the access to the meal eases the mental health conversation and makes people comfortable and willing to engage in all parts of that healthcare. And food, of course, food is just a piece of that. And that's something we end up talking about with a lot of navigators and organizations who are very close to people in their households. Awesome.
Dr. Rugless, wanted to put you on the spot. You are a true biostatistician, so you're knuckle deep into this data. And I'm going to ask a follow-up question for you, Julianne. How do we measure outcomes? So we talk about the food, we talk about the problems, we know what's going on. There are areas that have bad transportation, there are areas that have redlining. I talk a lot about that on my radio show. But how do we measure outcomes? How do we fix the problem, and how do we know that it's fixed?
I think there's 3 levels to that. One, I think it's the individual patient level. And then it's 2, your overall population as a whole, and then on the systemic level as well, seeing that. So on the individual one, you know, when it comes to improved lifestyle habits, or when it comes to a reduction in things, for instance, like your A1C levels or your blood pressure. So we're definitely tracking that, you know, among the patients and seeing improvements after the intervention or after some of these shifts. Definitely measure that before we start anything new. I'm adamant about we have to have a tracking mechanism in place, and we have to be able to have a pre-post and be able to compare and grow from that, and then be able to see it overall. So how is the overall population doing as a result of some of these interventions? And then systemically, is it making an impact across the board? So what we have developed here has been developing a food insecurity and food accessibility collaborative, in which bringing together all these different organizations that are addressing this food space together at the table at the same time, so that everybody's not in their own little circle in their own little space, but we're able to have a collaborative, larger impact within our region to make sure that we're being effective, to make sure that our reach is expanded, and then we're able to quantify and track that. And then this is able to live at that higher level, so that all parties that are involved and all parties that are touched, we're able to have a census of those numbers as well.
Julianne, same question to you. How do you measure? I know that you're in the stars, and he is where I'm a risk adjustment guy, so I can see the risk score. I can see if the members' A1C went up and down from a star perspective, but those are samples for NCQA. How do you measure at Clover Health? How are you measuring the results?
There's many different ways that we really look at this, and you know, and how we tie that back to, are we hitting the mark? And interestingly, with stars, you know, very interesting research that came out last year. A recent study showed that plans with lower populations with less diversity do better in stars than those with higher concentrations of diversity. A recent JAMA Health Forum found that MA plans that achieved higher star rating measures had higher magnitudes in quality disparity within their enrolled populations compared to the lower performing plans with higher populations of enrollees with low SES, or from historically marginalized racial and ethnic groups. And that's according to the emerging research. Because and so this really speaks to how we feel that we're doing, because recently, you know, we're a newer plan, and CMS recently upgraded our PPO plan to 3.5 stars on the Medicare star ratings for the 2020 measurement year, because currently over 90% of our Clover members are served through our PPO plan, and we had a 31% improvement on our CAP score for that same plan, which is our largest. So, and so we feel like those are some smoke signals that we're getting it right. For example, retention, members have a choice. And, you know, we talked about this a little bit ago. When member experience, such as our CAP survey, or even the health outcome survey, you know, when members feel like they're being taken care of and they're getting what they need and are able to use their benefits, and their plan is supporting them with whatever pops up, you know, they're going to stay. And then we're able to help manage those members over a continuum of time, and help affect change, because nothing is just overnight, right? I mean, things take a long time, because we're dealing with, you know, as you know, Joy mentioned earlier, you know, the right way to, you know, the healthier way to cook a food is with olive oil or something like that. Right. But, you know, you could have been grown up, you know, like my family, and they use bacon fat, right? Because that was what was available. But controlled A1C, blood pressure values, you know, are those key metrics for those members that have those chronic conditions that are those high price drivers? Are they controlled? Because we know that controlling those chronic conditions is a multi-pronged attack in medication, care team, behavior, and lifestyle. Food access, and when those levels are controlled, it's a good signal to us that something is working, and they're able to execute their own personal treatment plan. Another thing, you know, one of the many ways is just purely, and I'm talking about what are simple ways that plans can do, you know, if you don't have all the rich analytics and things like that, because I've been in a lot of plans where all I had was HEDIS measures to work with, you know, and like medication adherence measures. The more days a member has meds on hand, for those who are identified as having blood pressure or diabetes or needing a statin,
Right.
is important, as that's a strong signal for us that our formulary is correct and that our members are able to access those medications easily through their local pharmacies or mail order, and they're able to pay for those medications. We work, many plans work very hard with their formulary because many medications, for those key pieces, there's always new medications coming out, and they may be a tier 3 that have a price, associated with those. But a good PM and a good strong pharmacy team at your plan will be constantly, scrutinizing those and moving those throughout the formulary so that members can have access and use those.
Mm-hmm.
No, absolutely. So much to unpack by these three awesome women in the industry, just absolute rock stars. I got Rick Whithead he's the CEO of U.S. Hunger. And I got to give U.S. Hunger a shout out, and Sarah Davila and the whole team for helping to stream this webinar. And U.S. Hunger is a great partner of mine personally, and they're just an awesome group of people. Rick asked, from each of your perspective, what are the 2 barriers that make it most difficult for organizations to fully impact health equity and address the root causes of health inequities? I'm going to start with Joy, and then go to Fedoria, and then go to Julianne.
Well, like I said, I think it's a great question, Rick. And you want us to narrow it down to 2, right? Okay.
Right.
Okay. So I'm going to be good and give you 2 plus 1 and say the first one I think is we just haven't prioritized this in this country at this point, and let alone in your particular region, right? We know that when different groups, as everyone has said, come out of their silos and come up with solutions, there's some really great innovative solutions that have that exist and have happened. So we have to choose, and we have to choose to actually fund that. And then secondly, I think systemic racism is a real issue here, right? Geographically, within communities, expectations of populations, who deserves food access, right? It's very interesting to hear some of the conversations, at a level about, who is responsible or how you're going to reach populations and who deserves to be reached and who's primary. And those are tough conversations to hear. And they come back to this notion that, inequity is there and we're just going to have it, versus coming from a different perspective about it. And we run into that a lot. And then your last one, can I add gentrification as a sub area around racism? That gentrification, at least here in Travis County, is a key part of that. And we're driving these members and vulnerable folks further and further out, or further and further away from the very thing we're trying to get them closer to. And that's an ongoing theme for us here.
Gentrification could be another webinar series within itself, of impacting so many communities, starting to get into rural communities as well. Dr. Rugless.
I'm going to say, I'm piggy off of Joy a little bit with the 2 plus 1. I think first is political aspect, and ownership. So politics definitely at the governmental and administrative level when it comes to that. And then when it comes to ownership, it's like, okay, well, nobody wants to take all of this on. It's so big and it's so vast, and we just don't have capacity to be able to take it on. So, who's going to own it? Where's it going to live? And then the other one I want to add is sustainability. So a lot of times we may come up with a great idea and we jumpstart and we may do this and that, but then it peters out over a wall. And it's not sustainable over a period of time. And the people need that level of sustainability and accountability, that they know that this is a reliable resource that is going to be here. And then we can continue to grow and advance and expand what we've started. So I think those are the 3 barriers I feel for me in that regard.
Julianne.
I think there's so many, and I agree fully with what Joy and Dr. Rugless is saying. For us, I think one of our biggest challenges is screening and understanding who is vulnerable and needs support is so incredibly important, because, as I said, it's like we can't fix what we don't know is broken. And once that we're able to, understand and who those are, we're able to swoop in and wrap those supportive network around them. However, in designing benefits, recently last year we executed a $800 over-the-counter or food card, fresh food card for our members to be able to use, and that's great. And but if you think about it, like when I said, every member is a snowflake. It's developing a plan of action around each individual person, because and it goes to scalability. It's very difficult to scale across an entire population when each persona is completely different in what they need and the support they need. For example, in West Texas, in one of my previous plans, we had a tremendous uptick in ER visits, and we were like, what is going on? And so what we found out when we actually talked to some of these members is, if, in order for them to go to an urgent care, which they agree would have been the more appropriate care system, that was a 2-hour drive. And if anyone knows West Texas, that's a lot of, it's pretty rural. But the ER was down the street, and that's where they had access to. And so it's like what it looks like for each member in their situation. That's how it's like trying to scale personalization.
That is exactly it. And that's exactly what we used to say in technology. It was about scaling personalization and giving those personalized experiences. How do you do that in the right ecosystem, right? The ecosystem has to be able to help support that.
Absolutely. As we get to, so we have a few minutes left in the webinar, and wanted to thank everybody that has joined us. Wanted to thank Dr. Rugless and Julianne for their insights and their experience and really pouring into this audience and talking about what they're doing on the streets, not just in Austin and Memphis, but in their plans that are expansive. Joy, I couldn't have you on and really do this. I got to give you a couple of minutes to talk about the food itself.
Oh my gosh.
Motivational speech with the turkey sandwich, and it's just dripping with the mayo and all of that stuff. Tell us about the food and how awesome it is, and why, if you're someone that's coming out of an inpatient stay or an employee assisted program, or you're a health plan and wants to implement this, what are they getting in Cook's Nook if they bring Cook's in for the food?
Yeah, absolutely. So actually these days, we love talking about food. We have our Mosaic Meals program, which is our full meals, which includes, full entrees, which includes, protein, your carbohydrates and vegetables. And we also have our Mosaic Meals to go product line as well. And that one focuses on just the stuff you were talking about, the things that people love to eat and grab quickly all the time. What does a healthy sandwich look like with oat spelt bread, really, really good turkey, or, your own baked turkey inside. And then, plenty of vegetables, to be able to enjoy that, or even a chicken salad sandwich, same type of oat spelt bread, but instead of thinking about all that mayonnaise that you were just referring to, and goodness knows we love mayonnaise, but there's different ways to make aioli. I know aiolis and dressings that you control the sugar and salt contents of, that taste absolutely delicious, which is part of what we're doing. Asian chicken salad, reaching across to pull in lentils and different kinds of lentils. You probably didn't know all the different kinds of lentils that exist, out there, and how you can use them. What does it mean to have alternate proteins and may have less phosphorus or things in them for certain diets? So not only do we have those two lines, but we're also Mosaic Meals and Mosaic Meals to go, but we're also working on a series of renal meals that are just as delicious. There's no reason why you can't. You just got to make the right choices and have a very expansive set of things to access from around the world. And then additionally, what does it mean to be plant forward? And what does that look like? And what do those meals look like? And we don't necessarily segregate them. It's what are you trying to achieve? And what is that organization or that plan attempting to achieve? And what do we have in our arsenal of over 125 different types of meals? What is that? What works there, and how to ensure that they have choice and choice and range. And there's a lot of photos of some really tasty food on our website. So, that's the results of that.
I saw Joyce sent me the photos. I immediately went to Publix and tried to duplicate the food that I saw in the photos. Now, I'm not very good at that, so it didn't work out. But at least I tried. She got me off the couch and in the public trying to get some healthy food. As we wrap up, if you could just give us a synopsis, Joy. And once again, thank you for everyone that's tuned in. And we spent a fantastic time together, and really hope that everyone walks away with some knowledge. How does Cook's Nook align with the needs that Dr. Rugless and Julianne are talking about from a health plan perspective? How does your offering in food services and customer service and account management and leadership, all of those things, strategy, your years in tech, how does all of that align with the mission of the large health plans that ultimately will be soliciting you for your services?
Well, I think when folks talk with us, you've mentioned several of those arenas, right? I didn't mention this, but one of the reasons I talk about Travis County so much is that, we are really invested in impact in building the ecosystem itself that allows these things to happen, whether it's on, our regional planning committee, we have one specifically around food, and also our Austin Food Policy Board. So we also know in order to be able to even offer the quality meals that support the initiatives of the healthcare groups or the local organizations who are just trying to find really good food for their community members. In order to do that, we have to start with the whole string, coming back to some of the challenges that we talked about, actually affecting policy. But then additionally, how do you have an organization that's sort of leading these efforts from a business side, right? A for-profit business side, to sort of say, there's a role for us in this. We're happy to help lead, whether that is creating the right products for you or also thinking about your data, thinking about it holistically, and what your business and your organization's trying to achieve. And then additionally, it comes back down to, we know that there is a need here to help folks in our areas and even nationally, right? Even as we start to expand from here, that there is a population that we can directly affect and change, and we truly believe that, and we come to the table to do that, all the way up and down the chain. And so whether we're talking with a local organization about how to actually, what does it mean to literally have the food in your facility, to okay, what policies we even have as Travis County. Folks know that they have leaders who are actually doing it and help pioneer some of that in this arena. And now we're expanding it across the United States.
Well, thank you so much, Joy, and thank you for everyone on the Cook's Nook team. There are so many people that work behind the scenes to make this happen and put a lot of time and energy. Thank you so much, Dr. Rugless, Julianne, for joining. If you have any questions, you see the scrolling ticker at the bottom, cooksnooks.net, I believe. Yeah, there it is. Cooksnook.net. So if you want to contact me, hit me up, paragon7studios@gmail.com if you have any additional questions. Joy and I have a series on my radio show where she's talking about SDOH. So we're putting content out there constantly. And thank you so much. We look forward for the next time convening with the individuals that have been a part of this webinar. And thank you for everyone that's worked on this and taking place in this. It's very much appreciated. Everyone have a blessed day.
Thank you.
Thank you.